Assalamu alaikum, I am Maria Bhatti. Today we will discuss neonatal hypoglycemia, definition, types of hypoglycemia, etiology, clinical features, investigation, nursing management and medical management. So what is definition of hypoglycemia? Hypoglycemia is a metabolic condition in which blood glucose level of infant is less than 30 mg per del in first 24 hours of life and less than 45 mg per del thereafter. Types of hypoglycemia. There are three types of hypoglycemia. Number one is transitional hypoglycemia. The hypoglycemia in the first 48 to 72 hours of life is known as transitional hypoglycemia. And the second type of hypoglycemia is persistent hypoglycemia, the hypoglycemia that persists for more than 5 to 7 days. And the third is refractory hypoglycemia, that doesn't respond in intravenous dextrose infusion up to 20 mg per kg per minute. What is etiology of hypoglycemia? Number one is increased glucose utilization, that is sepsis and perinatal asphyxia. So the second etiology of hypoglycemia is decreased substrate availability due to IUGR, mean to say intrauterine growth restriction or retardation, and the second is glycogen storage disease. Third etiology is hyperinsulinemia, that is diabetic mother's infant, islet cell hyperplasia, abrupt cessation of IV glucose infusion and exchange transfusion in infants. So the fourth is endocrine abnormalities. Number one is adrenal insufficiency, panhypopituitarism, hypothyroidism and premature infants. And then there is clinical features of hypoglycemia, that is cyanosis, apnea, hypothermia, low body tone, that is hypotonia, and tachypnea, pallor, jitteriness, seizures and feeding difficulties. So why seizure? Brain depends on blood glucose as its main source of fuel. Too little glucose can impair the brain ability to function. Severe or prolonged hypoglycemia may result in seizures and serious brain injury. So that's why seizures occur. And jitteriness means involuntary movement in newborn. So the next point will be investigations of hypoglycemia. So there are three hypoglycemic investigation. Number one is serum blood glucose, number three is heel stick BSR, and the third is umbilical catheter blood glucose checking. So the next is nursing management of hypoglycemia. So the first point is early initiation of breastfeeding is very beneficial. Second, maintain normal body temperature. Baby should not be hypothermic. And the third is regulate thermoneutral environment. Fourth is monitor carefully the condition of neonate. Number 5 is glucose infusion may be prescribed for the neonate. The infusion rate must be regulated and decreased gradually. Oral feeds are introduced gradually. Closely monitor the blood glucose level. Number 7 is closely monitor the respiratory status of the neonate, and the supplemental oxygen may be administered to prevent the hypoxemia. Hypoxemia means less oxygen in the blood. The infusion is gradually decreased and then stopped, because if the infusion is stopped abruptly, there is risk of hypoglycemia. So what is medical management of hypoglycemia if the infant is hypoglycemia? It should be asymptomatic and symptomatic or sick. If patient or infant is asymptomatic, on enteral feed, and if not taking enteral feed. If taking enteral feed, check blood sugar before every feed, and if blood sugar level normal, then continue feeding. monitor blood sugar level till 2 readings in normal limits and continue feeding, hand over to the mother. And if hypoglycemia persists and after feed, so then dextrose 10% IV bolus, that is range from 2 to 5 ml per kg, given to the infant. If then again it persists, then start 10% dextrose IV infusion at the rate of 4 to 5 mg per kg per minute, and then monitor blood glucose half hourly for the first hour and 1 hourly for the 4 hours, then 2 hourly till 2 consecutive blood glucose readings are normal. Then if hypoglycemia resolves, monitor blood sugar level for the next 24 hours. But if hypoglycemia persists, increase the glucose infusion rate by 2 mg per kg per minute up to maximum of 15 to 20 mg per kg per minute. But if again refractory hypoglycemia or hypoglycemia resolved, then monitor blood sugar level for the next 24 hours. But if refractory hypoglycemia present, refractory hypoglycemia that doesn't respond to IV dextrose infusion up to 20 mg per kg per minute. And then refractory hypoglycemia, inform the consultant, continue dextrose infusion, send investigation to find out the underlying etiology, that is insulin, FFA, free fatty acids, serum lactate, urinary ketones, cortisol, human growth hormone and thyroid function test, and injection hydrocortisone 2 to 5 mg per kg per IV 12 hourly given. If hypoglycemia resolves, then continue feeding and consult to pediatric endocrinologist. But if hypoglycemia persists, then further drug and treatment options to be employed in consultation with pediatric endo. Use of glucose polymers in feeds. Then diazoxide loading dose will be 5 mg per kg per dose per oral 12 hourly, and maintenance dose 1.5 to 3 mg per kg per dose orally. And somatostatin analog 2 to 5 microgram per kg subcutaneous 2 to 8 hourly or by continuous infusion. So this is the management. So if you like my video of hypoglycemia, then subscribe my channel and like my video and share my video and suggest me the next topic which you want to learn. Thank you and Allah Hafiz.